this module is basically about decay. So what is that we need to know about decay, and then we'll come to HHS. What is decay? Decay is very often the presenting manifestation. That's the most important part in a type 1 diabetes. So very many a time what happens is this type 1 diabetes doesn't get diagnosed. I have seen people who have gone around with vomiting 3-4 places. Every time somebody comes with vomiting, they'll give pantopneumocid, vomiting subsides, he will go home, again come with vomiting, and later on he may be actually brought in a very bad state. That may be the time he may be diagnosed with decay. So decay can have so many presentations, which will come to that. But before that, let us see what is this decay per se. So decay is a state of insulin deficiency. Do you agree? Yes, decay is a state of insulin deficiency. But is decay just a state of insulin deficiency? There is a severe insulin deficiency here. I'm actually putting on a scale of 10 means HHS I would say will be like 1 out of 10. Insulin deficiency is there, but it's not severe. Here I would say on a scale it will be 9 out of 10. So there's so much of insulin deficiency. But simple severe insulin deficiency alone will not produce decay. Because if you are having severe insulin deficiency, all these free fatty acids will actually come out because of lipolysis. They will go to the liver. But they have to enter into the mitochondria. For them to enter into the mitochondria, who has to be expressed? Carnitine palmitoyl transferase has to be expressed on the membrane. If on the mitochondrial membrane, then only it can go to the mitochondria. This will not be normally expressed. So severe insulin deficiency alone can never produce decay. Severe insulin deficiency can sometimes produce hyperosmolar hyperketotic state, or what we call HHS, especially in elderly people who are having other comorbidities, who are dehydrated, etc. It can happen, but it can never produce decay. So for decay to happen, you must have so much of counter-regulatory hormone excess. So the basic point about decay itself is that it is not about insulin resistance, or it is not about insulin deficiency. The severe insulin deficiency understood, but there has to be counter-regulatory hormone excess. Glucagon, epinephrine, all these have to be released in excess. This counter-regulatory hormone excess that you are talking about is responsible for CPT being expressed. When CPT is actually expressed, what will happen? All this will actually go to the mitochondria. Once they go to the mitochondria, there will be so much of acetyl coenzyme overloading in the mitochondria. This is much more than the acetyl coenzyme which can go to the TCA cycle. So acetyl coenzyme will go to which cycle? It will go to ketone body pathway. Acetyl coenzyme will form HMG coenzyme. HMG coenzyme will form your acetoacetate first, and then from acetoacetate, this is the primary ketone body, you can have acetone being formed, and also beta hydroxybutyrate being formed. These are the secondary ketone bodies. So this is what is going to happen. Correct. Acetyl coenzyme will combine with acetyl coenzyme, from acetoacetyl coenzyme, from that HMG coenzyme, you know the cycle. So there it actually ends up with acetoacetate, which is the primary ketone body, then acetone and beta hydroxybutyrate. So this is basically what is happening here. So literally, where is the problem means decay is a state of severe insulin deficiency plus counter-regulatory hormone excess. That should be your answer. And in this state, because of severe insulin deficiency, what happens is this fructose to fructose 6-phosphate, right? Fructose to fructose 6-phosphate. This is with the help of the enzyme called phosphofructokinase. Okay. This phosphofructokinase can also act in this direction. That means it can be even a fructose 1,6-bisphosphatase. Okay. Fructose 1,6-bisphosphatase. So fructose will be converted to fructose 6-phosphate by phosphofructokinase. Fructose 6-phosphate can be converted back to fructose by fructose 1,6-bisphosphatase. This is under the control of something called fructose 2,6-bisphosphatase. Biochemistry only, but clinical biochemistry. Fructose 2,6-bisphosphatase will determine in which direction this reaction will go for. Which direction this reaction will go for. If you are having good amount of fructose 2,6-bisphosphatase, then the reaction will go down the direction of glycolysis. So if you are having enough fructose 2,6-bisphosphatase, a positive regulator, PFK will be stimulated, reaction will go down to the level of glycolysis. In a decay, what happens is that this fructose 2,6-bisphosphatase is reduced. So when fructose 2,6-bisphosphatase is reduced, instead of going in this direction, it will go in the reverse direction. So more and more glucose will be produced. So that's a major issue that you are talking about here. Okay, so let us see the biochemical aspects once again. Insulin deficiency with excess counter-regulatory hormones, perfectly correct. Reduce fructose 2,6-bisphosphatase, correct. Because of insulin deficiency, reduce GLUT4, correct. Increase free fatty acid lipolysis, correct. Why ketone body? Because CPT is actually expressed. That is the story of CPT. Okay, most of the patients with decay we'll see, we are able to bring them out. Okay, if you ask for mortality in decay, adult decay mortality is actually very less. You ask me, it's very, very less. But child decay, there are cases reported, or we have seen so many patients die. I have not seen, but like there are reports like that. Childhood decay, I have not managed. The decay that we manage is 10 years plus. So childhood decay, why there is so much of mortality is because of cerebral edema. So Most common cause of death in DK, if you get a question for the exam, the answer is cerebral edema. But I once again repeat that cerebral edema is not common to see in adults, it's common to see in children. Okay, so now what happens in DK? When do you suspect DK and all these things we come to? Okay, so what is DK in toto? DK is a case of absolute insulin deficiency plus increased counter-regulatory hormones. So absolute insulin deficiency, increased counter-regulatory hormones. This is actually leading to a state of hyperglycemia. Okay, this hyperglycemia will lead on to glycosuria, and the glycosuria is basically osmotic diuresis. This osmotic diuresis will lead on to dehydration. This is one way you can look at it. Another way you can look at it is that there will be ketone bodies being formed. So ketonemia, ketonuria, that will lead on to high anion gap metabolic acidosis. That way also you can actually think. So metabolic acidosis is there on one side, dehydration is there on the other side. These are the two most important aspects, or essentially we say the most important aspect out of everything will be dehydration, because intracellular dehydration is what is happening. So by the time you are having dehydration in the patient, already there will be so much dehydration intracellularly. Then only you'll be having extracellular dehydration. So this is what is happening here. So why this case of absolute insulin deficiency plus counter-regulatory hormone excess? So general state you are having insulin deficiency, will you get counter-regulatory hormone excess? No, you will not get like that. So when do you actually suspect this, or when does this happen? That is why it's so important to keep in mind that, or if you are asked to tell your junior one point about DK and give him one strong message about DK, that message that you have to be continuously giving him is DK occurs only in the presence of a stressor. Without a stressor, you will not get DK. So when you find out DK, don't be happy with DK, go for the cause. If you don't figure out the cause, you are in trouble. First year PG, I was actually doing casualty duty. I am there, my house surgeons are there, my senior PG is also there. We are seeing a patient who is having type 1 DM already. He's basically come with he's already having type 1 DM. He's come with dyspnea, which is like more of an acidotic breathing. On seeing him itself, we know that this is a case of DK. We are admitting him, we are putting 2 lines, we are starting treatment, and we are happy, and we are actually, keeping him in the 0 delay ward. And as his sugars will come down, we'll actually shift him. I am happy with the thing, and we are actually getting back to work. So when the ECG technician comes to take ECG, we have this routine habit of taking ECG for everyone. And we took ECG to find out that that fellow had ST elevation MI. So we missed the bus completely. Another patient whom we treated for DK, everything was okay. Next day morning, we started looking at the patient and found out that the patient was not moving his limbs. So I thought it may be because moving one side limb. When a patient doesn't move the limb, that's because potassium correction is not correct. Because when you give insulin, potassium will go to the cell. So hypokalemia is part and parcel. We see hypokalemia. But hypokalemia cannot have one side weakness. It will have both side weakness. We understood one side is not moving. Again, took CT, found out he had stroke earlier on itself. DK was precipitated by stroke. So precipitating factor is so crucial, man. So always look for vascular issues. Okay. ACS or stroke or something like that. It may be there. It may be even infection. Infection is a very important precipitating factor. It may be a pneumonia, it may be UTI. So checking for that is extremely crucial. Infection, then inadequate insulin. Or patient may have skipped insulin. This is also very common to see patient not taking enough insulin. Pregnancy is another thing which can actually precipitate. Cocaine is another thing that can actually precipitate. That's why this table is very, very, very important. Inadequate insulin, infection, pregnancy, cocaine, infarction, all these things can precipitate a DK. So what can actually precipitate a DK? All these things can precipitate a DK. It's very easy to diagnose DK. It's not a big deal diagnosing. If a patient is a non-diabetic, if a patient is not a non-diabetic, then you are in trouble. You have to have high index of suspicion. Patient is a known case of type 1 DM. Anytime he comes with a complication, you know it is DK. But the fact is, you shouldn't miss the underlying thing. It may have been precipitated by an infection. Very important, check for pneumonia UTI. Very important, check for ACS and stroke. Very important, look for cocaine. And then, of course, for the exam, always keep pregnancy in mind. Okay, or he may have missed his dose. That's also possible. Now, the part about diagnosing DK. Now, see, if you ask me how easy it is to diagnose DK, I would say if you know the patient is diabetic, it is so easy to diagnose DK. The problem is first time when somebody has a DK presentation, if you don't have this index of suspicion, you will miss. That's why always keep in mind presentations. Anybody who is coming with nausea, vomiting, especially young male around 20 years without any particular cause and having tachypnea, tachycardia, Nausea, vomiting with tachypnea, tachycardia, and having this history of extreme thirst or polyuria, all these things always keep in mind that things can go terribly wrong. If you ask me about that one symptom in medicine that I'm really afraid of, if you ask me, which I have basically got no clue if you ask me, that is vomiting. Because vomiting is that one symptom which can be present in a very simple gastritis to an extremely complicated brain tumor with increased intracranial tension. So vomiting can have such an array of causes, and if you have seen those causes one by one in a casualty, you will know that anything can happen with respect to vomiting. And you have to be always guarded with respect to vomiting. And my experiences with vomiting have been very strange also. We've seen a patient again, 25-year-old male, who came at night 4 a.m. to the casualty, who was having extreme vomiting, abdominal pain also, abdomen was soft, bowel sounds were normal, so the surgeons actually sent him to us. We were okay, that's fine. We actually tried to send for CBC, RFT, took a ECG. ECG also did not show anything. And we were happy, and the patient just like that collapsed and died. There was a big row in the casualty. We have no idea what happened. We were asking if he's alcoholic, had he consumed something, was toxin involved, nothing. And then came the result of the blood sample we had sent to show creatinine 22. It was uremia. So uremia can produce abdominal pain and vomiting. I've had my own colleague who just kept on seeing a patient with vomiting. First time vomiting, wrote something and gave. Second time vomiting, wrote something and gave. Third time she went to some other doctor, found that she was pregnant. Pregnancy was the cause of vomiting, and this fellow was sued. So you can have so many issues like that. So vomiting is a very, very much kind of a finding which can betray you at times. So please be careful. Vomiting sitting, always keep DK in mind. Okay, especially if vomiting with tachycardia, vomiting with tachypnea, tachycardia, thirst with vomiting, drinking water so much with vomiting, polyuria with vomiting, always keep it in mind. Second is metabolic acidosis can produce acute abdominal pain. So anybody coming with medical acute abdomen, again we have discussed this topic so many times, I guess. Medical acute abdomen is a very important disease consideration. That means somebody comes with abdominal pain to the casualty, it is surgical unless otherwise proven. So surgeon will always examine the patient first. He looks for bowel sounds, he looks for guarding, he looks for rigidity and all those things. Suppose he feels nothing of that kind is there, then it is a medical acute abdomen. Medical acute abdomen has got a lot of important DDs, especially MI. Upfront take an ECG and look for ACS. Then DK, very, very important. Crohn's disease, very important. Hypercalcemia, very important. Addisonian crisis, very important. Lead poisoning, very important. Even from the textbook, porphyria, acute intermittent porphyria, very important. So all those things have to come to mind. So acute abdominal pain, always keep in mind. Acute onset dyspnea. We have done so many modules on clinical approach to findings. In edition 5, we have done revision videos for all clinical approaches. In the clinical approaches, acute onset dyspnea I have discussed. Whenever somebody comes to the dyspnea, chest and all you examine is full normal, okay, air entry full normal, but patient is dyspneic out of proportion to lung signs. There are only two things that you can think. One is pulmonary embolism, second is metabolic acidosis. Pulmonary embolism, metabolic acidosis will have dyspnea, but dyspnea will be disproportionate to lung signs. That's why in metabolic acidosis patient will feel acidotic breathing, but essentially he will be having no signs on examination. So that's why these are the three settings where I want you to actually keep in mind. And clinical findings that you look for in the patient, dehydration is something that you can look for, tachypnea is something that you can look for, tachycardia is something that you can look for, all these things you can actually look for. This is our DKA patient. So I think I've made it very, very clear. Symptoms we have discussed, tachypnea, tachycardia, sometimes dehydrated patient, Kussmaul's respiration because of acidosis, abdominal pain may even resemble a pancreatitis. That's what I'm saying. Sometimes you may even think it is pancreatitis due to so many reasons. Amylase may be slightly high also. So never miss it, okay? Never ever miss it. And cerebral edema is the biggest complication. Because of acidosis, you can get arrhythmias also, that is there, but this is the biggest complication. Fine. So I think you've understood. Now let's see how you manage this, then we'll see how to differentiate. So how do you manage? As soon as you see the patient, I think all of you know this. The most important part is to replace the water deficit. That is the most important part. What is the integral part of treating DK? If you answer insulin, giving insulin is the integral part of DK, means you better stop and go somewhere else. Okay. That means that you have had absolutely no idea what is happening with respect to a case in the casualty. Means if it is DK, it is equal to water, fluid replacement. So water deficit in DK can be as much as 9 liters. Okay, it's such high levels of water deficit. So you put two lines and you start rushing NS. We give about 3 liters of water in the first 3 hours itself, next 3 liters of water in the next 6 hours, and another 3 liters of water over the next 12 hours. NS or RL you can use. This is the basic point. So 2 lines. So as soon as you see a patient, the house surgeon's responsibility is to put 2 lines and start hydrating. Okay, 1 line we continue hydration. Next line, after we complete IV fluid 500 ml on this side, 500 ml on this side. So almost like 1 liter is done. We start thinking about giving insulin. Okay, start thinking about giving insulin. When we give insulin, of course, it is only regular insulin that you give, no other form of insulin you give. 0.15 unit per kilogram IV stat is what you give. So 0.15 unit per kilogram IV stat. So on an average 6 units or 7 units or 8 units depending on the weight of the patient. After which we start an infusion. Okay, after which you start an infusion, which is 0.1 unit per kilogram per hour infusion. 0.1 unit per kilogram per hour infusion. For example, you take 25 units regular insulin in 500 ml of NS. Okay, 25 units units of regular insulin, 500 ml of NS, and put it over 5 hours. Put it over 5 hours, which means it will be 100 ml per hour. 100 ml per hour is equal to 5 units per hour. So you make it as 5 units per hour. Then at the end of 5 hours, you make it 15 units in 500 ml NS. 15 units in 500 ml NS. 15 units in 500 ml NS over 5 hours. So what is it? It is equal to 3 units per hour. So first it was 5 units per hour, then 3 units per hour. If the glucose levels are less than 200, we can change the vehicle to 10% dextrose. Otherwise, you need not change the vehicle. You give it in NS itself. So first 5 hours, we have given it 5 units per hour into 5 hours. Then we give 3 units per hour into 5 hours. So 10 hours have gone. Now 1 unit per hour we give into 5 hours. So what do? You put 5 units of insulin in 500 ml NS and run it over 5 hours. So 1 unit per hour. So 15 hours. When 1 unit per hour is actually going on, you have to overlap, because now the patient is on insulin infusion, hydration is going on one side, and you are very happy, patient will be improving, dramatically improving. Then you have to give regular insulin subcutaneous. So regular insulin subcutaneous, we'll discuss again during management, is given on the basis that a normal patient requires 40 units of insulin per day, provided he is not having resistance. So we assume this is a type 1 patient who is having no resistance. So this 40 units, we divide it into 888. That is 24 units of short-acting insulin we give. Okay, and 16 units of long-acting insulin we give. So 24 units of short-acting insulin, 16 units of long-acting insulin. Long-acting insulin, we prefer Glargine, or we can even give Degludec now. We'll see what is Glargine, what is Degludec, etc. That's what we prefer. 8 units short-acting insulin, that is your regular insulin. 8 units, 8 units, 8 units, 3 times. This is 16 units at night. So 8 units at around 7:30, have meal by 8 o'clock. 8 units at 1:30, have meal by 2 o'clock. 8 units at 7:30, have meal by 8 o'clock. And night bedtime, 16 units Glargine. Okay, and then depending on values, we'll change. Depending on next day, how many values you get. You have to go for maximum values. Pre-meal, at least 6 values. Pre-lunch, post-lunch, pre-dinner, post-dinner, pre-breakfast, post-breakfast. That we'll see when we study management of diabetes. So essentially, this is how you manage. And very, very important to keep in mind that potassium replacement has to go hand in hand, because if you don't replace potassium properly, patient will be all right tomorrow, but he will not move his limbs. So potassium is very crucial, because insulin will result in potassium going from the blood to the cell and produce hypokalemia. So DK per se, you can get hyperkalemia, but that's not what is relevant. After giving insulin, potassium will go into the cell, produce hypokalemia. That's why we are taught that you put 1 ampule KCl for every 1 liter of fluid you replace. So 1 ampule KCl for every 1 liter of fluid you replace. 1 ampule KCl is 10 ml of KCl. 1 ml contains 2 millicoulomns. 10 ml contains 20 millicoulomns. So 20 millicoulomns of KCl for every 1 liter of fluid you replace. If you have any doubt with respect to managing this, practically, you please take the phone and call me. Anytime you can actually do that. I'll be very happy to help you. Rather than asking what is the answer of this MCQ, etc., you can always ask me this. That's fine. Okay, so ketonemia, ketonuria, hydration, water deficit. Serum osmolality is 2 into sodium plus blood glucose divided by 18 plus blood urea nitrogen by 2.8. Here naturally you are having glucose high, so osmolality will increase. Potassium will be on the lower side. Bicarbonate, you'll be having acidosis, but unless and until pH is less than 7.1, we don't go for any kind of a bicarbonate replacement. It's not generally required. Phosphorus will also fall. Like potassium, phosphorus will also go to the cell, but I told you in my phosphorus module, it's not too low for a correction. So you don't have to correct it basically. Correction part means only 3 things. Give fluids, most important. Give insulin and give potassium. That's the only thing. Okay, as soon as you admit the patient, you are suspecting DK, you will put a catheter and you will actually send urine for ketones. Sending urine for ketones, don't bank on the test so much because beta-hydroxybutyrate cannot be picked up by that. Only acetone will be picked up. So being negative doesn't really mean a lot. Okay, being positive, of course it is. And at least don't keep on repeating it again and again. Once positive, be positive for 3 or 4 days, etc. So again, that has no value. House surgeon is always happy because you get a chance to take the ABG, and ABG will actually show high anion gap metabolic acidosis. High anion gap metabolic acidosis. So sodium minus chloride plus bicarbonate is your anion gap. 8 to 12 is normal. Here you will definitely be getting a high anion gap metabolic acidosis.